Hi, this is Eric Prystowsky. Welcome to another segment of EP on EP. It's a delight to be with Andrew Krahn today, a person I've known for many years and respected his work. He's currently the head of cardiology at the University of British Columbia in Canada. Andrew, welcome.
Thank you. Nice to be here, Eric.
So, you not long ago presented at the Late Breaker trials a wonderful study on looking at whether or not you change your paradigm for antibiotics when you put in devices. So why don't you educate our audience on sort of why you wanted to do the trial design, and then maybe we'll get a little bit into it.
Sure. I've had a long-standing interest in devices and quality, and infection is obviously a concern. I took up the banner of lead extractions, and the major reason to do that was around infection. And the question of what the best way is to prevent device infection came up. And the researcher part of me said, what's the clinical study that would help us identify the best way? When you look at the literature and our guidelines are quite simple. There's a single dose of intravenous cefazolin as the bedrock, if you like, of how we treat things. But the reality is the amount of data to support that decision or incremental antibiotics is not great. If you do a survey out there of what people are doing the whole range of incremental antibiotics, and not systematically. They're mostly not collecting data.
May I stop you just for one moment? I don't know that everybody understands what you mean by incremental antibiotics. Yeah. Could you just kind of define that for us?
Sure. I think everyone assumes. So there was a placebo trial back about 10 years ago that looked at placebo versus cefazolin that showed a dramatic effect, and it was stopped early because of the infection difference. So we'll make the assumption we all start with cefazolin, and the question is, what do you add to that?
Okay, that's what you mean by incremental.
So incremental being, for instance, do you add additional intravenous antibiotics? Do you add antibiotics after the procedure, and so on? Do you pick who you give that to? Who are the people at highest risk? Those kinds of questions. So I was trying to define, what research study would need to be done. When you look at the literature, you start off with saying, what's the scope of the problem? And the literature would suggest the risk of infections in the order of about 2%. There's more risk in patients with longer procedures, with repeated procedures, revisions, upgrades, generator replacements, CRTs, those kind of things. So if we think that there are risk of infections in the order of 2.5%, if you're trying to make a difference to that, you need a large-scale study. So I pitched to the Canadian heart rhythm community that we would collectively work on a study where we would do this. And the development of that moved towards a study design that uses what's called a cluster crossover design. So what's different about that is, although we are looking at patients and infections, what we're studying is actually hospital infection rates. So what you do in that situation is you take your standard orders for antibiotics and you administer them systematically to every patient over 6 months in this instance, and then you look at the number of patients who develop infection. And then you cross patients over to the alternate antibiotic strategy.
At that same hospital?
At that same hospital.
Okay.
And then you randomize them again to a different order. So you have sort of 4 treatment periods where everybody gets the same antibiotic.
Okay.
And then you look at the outcome of those patients and whether they get infection by 1 year. That's the end point of interest.
Okay.
And so what we did is we then administered the incremental therapy was not only the cefazolin that everybody gets in the conventional arm, but also vancomycin preoperatively.
Okay.
They get an antibacterial wash of the pocket. We use bacitracin because it happens to be the most commonly used agent in Canada for that purpose. And then 2 days of an oral cephalosporin after that.
So let me stop you there. There must have been some thought that went into, I'm sure there was, why you would, because you have a long study with huge number of patients, you must have figured somewhere this was the best incremental. Now, I can understand the vancomycin, I can even understand the wash, but how did you come up with 2 days of oral antibiotics? How was that added?
So there's a steering committee. It includes infectious diseases experts. We tried to get some input from them. They bring in the perspective of the whole surgical site infection, prosthesis infection management with literature in the area of orthopedics, in neurosurgery, for example, where they also have retained foreign materials and so on. So for instance, the 2 days of oral antibiotics was based on a cardiac surgical study looking at sternal wound infections.
Oh, so it did come from some other study.
So it came from another study, and there is some evidence that once you extend antibiotics beyond about 5 days, you start to induce change in gut flora and sharply increase the chance of C. diff and so on.
Okay.
So fundamentally, it was one of those short-term antibiotics have very low risks, and 2 days was felt to be better than nothing, but not long enough to cause trouble.
I got it. So it was a compromise.
Yeah.
Okay,
Yeah.
Go ahead, I'm sorry.
Yeah. So there is some basis to that. So then in the end, our primary endpoint was hospitalization for device infection after 1 year.
Okay.
And there's speculation about whether infections can happen later than 1 year, how much it's related to the procedure versus seeding and so on, but 1 year was sort of a pragmatic endpoint. And in the end, what we found was hospitalization for infection was reduced by 23%. But because of the scale of this and the absolute risk of infection, that did not achieve significance.
Yeah, so I was fortunate enough to be at your presentation. As I remember, the overall risk was a little more than 1% in the what you would call the standard group, right? That was a surprise, I suspect.
Yeah, this study was in 19,000 patients, and the overall infection rate was 1% in the conventional and about 0.8% in the incremental arm. If you took the higher risk group people, that group of people with CRTs, upgrades, revisions, replacements, their risk was only 1.2% in conventional and 1% in the incremental.
Let me ask you, what about often patients with diabetes or renal dysfunction? Was there any marker you saw there?
So, if you read clinical trial papers, you see these things called forest plots, where it tries to look at whether the odds ratio suggests an interaction where it seems to benefit males more than females, or like you say, diabetics, non-diabetics, renal failure, and so on. And one of the striking things in the trial was there's an absolutely uniform effect.
Okay.
So that argues that it's not concentrated in a certain group. It also argues that it may be real. Even though the p-value was 0.1, it may be that there's a moderate benefit in the order of 20%, but that benefit is modest enough. A trial of the scale that we did, even 19,000 patients, isn't sufficiently large because the risk is only 1%.
So, wonderful trial, by the way, congratulations. That's a tough trial. And now comes the obvious thing. So I'm just this clinician who's running a group of EPs back in Indianapolis, and I don't implant, but I have a group of people implant, and they're going to ask me when I come back, so Eric, you had a chance to speak with Andrew Krahn, right, personally? And I said, yeah, I did. What did he say? So were we supposed to switch? So what are you doing?
Sure. That's a very good question. So, I'll take the defensive posture and say that there's still a little bit of work to do to sort through some of the data and some analysis, but I think we need to take action based on the big picture. So some of the decision making is, let's say, for sake of argument, that we are not stuck on the p-value so much as the effect. And we say, what this means is you'd have to treat 500 patients to prevent one infection. And in your institution, with the way the process works, is that worth it or not? This is based on the fundamental notion that if you look at the trial, the risk is very low in these patients. So you need a system in place that gets your ambient risk low. So this may not apply to an institution where the risk is 4%. Those people need to look at their own processes and ensure that they have standardized processes. And in fact, antibiotics may offset the fact that they don't have ideal, for instance, airflow in their room. They may not have ideal glucose monitoring in diabetics. They may not have ideal surgical technique in terms of hematoma management or cautery. The reality is that if you feel you have all those ducks in place, and then you have to make the decision, I think what most people are going to do, and what we're doing, is we're looking for the people we perceive to be the highest risk and taking every reasonable measure to prevent infection. The risk in this population, there were 50 adverse events in almost 20,000 patients. There's almost no downside to this other than the time to do it. So if you have a CRT upgrade and the patient's got a fibrous pocket and they're diabetic, I see little harm and an immense potential gain, even if it's modest, to give that person the incremental antibiotics. On the other hand, you have a new pacemaker on a patient. The risk is low to begin with. They don't have other comorbidities that place them at high risk. Those are people I would probably just give the cefazolin and move on.
Gotcha. So again, wonderful study, food for thought, because you're right, it's not always about the p-value. You have to look a little deeper than that. I suspect people who've been doing that approach are going to feel like they've been justified to do it. And for the people who never wanted to do the approach, they're going to say, you haven't proved it to me yet. I mean, that's how people are.
Right.
I hope that people go beyond that and start to individualize the way you're suggesting, because it seems like they were better, just not a p-value better. And so that it's not all about p-values, right? When you're dealing with things like you have to pull out someone's pacemaker dependent, And you know what I mean? One of those things where when you have to extract that system, you've got a big problem on your hands. So I like your point of think through it for each patient. It doesn't have to be a universal policy. I think that's kind of what you're saying.
Yeah, I think one other comment that's already come up that we thought about as we sort of depicted these results is, how could the rate only be 1% when the literature and other registries suggest it should be higher than that? And one of the answers is, it is possible that by conducting a trial where you're telling people, hey, we are collecting infection information, we want you to tighten your belt for your system for prevention of infection, of all the many aspects that are not antibiotics. The patient factors, the health team factors, the device factors, all those elements of things. So one of the take-home messages, I think, is if you can get yourself to a system that has centralized, high-volume, systematic care of patients, that may be as big an increment to people as the antibiotics.
Yeah, no, I thought about that when you were presenting.
Yeah. So it's almost a health services research, not an antibiotic question.
I think that's really a good point. Well, listen, thank you for educating our listeners, and thank you for doing such a great trial.
You bet, and I look forward to hearing how our community then digests this and then puts it into practice.
Yeah, well, maybe same time next year.
You bet.